Hi there, everybody. My name is Jill Attaman. I'm one of the reproductive endocrinology and infertility physicians with Boston IVF. It is such a privilege to be here with you today in the afternoon if you're in the same time zone, and on a snow day if you're in the relative same area that I would be, which is the New England area. It's a beautiful day outside if you're not driving, but stay safe and stay warm. So during the next half hour, I will have an opportunity to take some questions from individuals, talk about fertility. This is something I'm extremely passionate about. I've been practicing for years. I love in vitro fertilization, family building, IUIs, just having individuals help bring what they need forward is the best part of my job. So if I can do any of that by answering some questions for you today, then I will feel accomplished and grateful to you for being with me. All right, so I suppose that's enough about me and why I'm here. I do have some questions that were submitted, and then you can pop them into the Q&A and I will go from there. But initially, the first question that I have on the list, and I will read the questions as well, just so you have a good understanding of what I'm answering. So the first is, can you please comment on the process for transferring care to Boston IVF? Oh, well, we will love you at Boston IVF. Thank you for the question. This is a great way to start. After already establishing care at another clinic, are you able to comment on time frame to start IVF? Okay, so a lot about timing. So it's not uncommon that individuals have started a process somewhere, whether a move takes them to a different place, or logistics. There are so many different ways that life takes us that we don't expect. But if you are coming into Boston IVF, just calling the main number, identifying if there's a physician that you are most interested in seeing, if you've had a personal referral, or if you want to see any of us. I think we have an amazing team and would promote all of my colleagues. I think it's a great place to be. And we have wonderful support staff, and we have great nurses and um, folks that are in the operating rooms. I could go on and on, phlebotomy and sonographers. So, yay, if you do need a transfer of care to Boston IVF, call the main number. They'll help you get records over if you have records. Those records ideally go to your physician that you end up seeing prior to the visit so that they can be reviewed and questions can be answered. If all the testing is complete, then you may be talking to a doc about starting an IVF cycle and developing a plan. If all the testing, well, if some testing is outdated, or if your physician needs something that they think would be helpful to you, that could take a little bit of time. But in general, it takes time depending on where you're at to actually start an IVF cycle. If you have to go through the insurance process for a prior authorization, that estimate's very different than if that's not occurring. But I would say on average, where I'm currently at, we could be looking at, weeks or more before a process is started. And it's not because we're holding anybody up. We're just going through the steps that are necessary to take really good care of you and make sure that we're meeting your expectations. All right. Hopefully that helped. But give us a call. Can you speak to the IUI and IVF choices that can be made for lowest risk of multiples? Yes, absolutely. So it's really been such a trend that I'm grateful to be part of over the last, decade and plus. We've been seeing a decrease in multiple pregnancies and an increase in singleton gestation, so one pregnancy at a time. And that really is the safest type of pregnancy for individuals to have, in the way that we generally have pregnancies and unassisted conceptions. This is different for everybody, but IVF has really given us a nice opportunity to transfer a single embryo for many individuals, which really gives a nice low probability of multiple gestations. Transferring one embryo that has been in the culture environment is a high quality embryo. Perhaps it's an embryo that's had genetic testing, perhaps it isn't. But most of the time, we are in positions where we can place one embryo at a time. It does not mean that an embryo can't split. It can after it's been placed into the uterus with an embryo transfer, but that doesn't happen in the majority of cases. We also try to aim for one pregnancy at a time with intrauterine insemination. So with an intrauterine insemination, when the sperm is being placed into a uterus, the number of eggs that are present could be multiple, depending on whether somebody has been on medications to create multiple eggs or not. Or it could be in a cycle where we're just following a follicle growing and there's a single egg present. So it really does depend on circumstances there as well. But in general, if medications are being used for ovulation induction for somebody that already ovulates, there's about a 10% chance of twins, less than 1% chance of triplets or more. That's a pretty high risk pregnancy. And if a singleton pregnancy is the goal here, I would say that IVF gives you a really nice opportunity, but there are other options as well. Okay, the next question. What is the ideal number of eggs to retrieve for a high IVF success rate? Well, this is a great question. Thank you for asking. I think that this comes up so often because there's so much in IVF that we hear about in numbers. We're hearing about number of follicles as they're being monitored for growth during an IVF cycle. We're hearing about size of follicles and if there are more than what there were a couple days ago. And then there's the egg retrieval where we're hopeful for a certain number and then we get that number back. So there is a focus on quantity. Now, that does not change the quality of the eggs or the eventual embryos. But in general, what I say to this question is we do the most that we can that keeps you safe during an IVF cycle. So ideally, this number would be something that we can select, but it's not. It is based completely on biology. A physician that you see can give you a much better estimate if there's some preliminary testing that helps physicians understand how stimulation will occur. For example, the AMH level, which is an anti-Müllerian hormone level, or FSH, antral follicle counts. These things can help give estimates, but there's no one right answer here. It's what your body can do safely such that you don't get sick during a cycle with hyperstimulation syndrome, which is potentially quite dangerous. We will do everything we can to make every cycle as successful as possible. I'm 33 years old and have two embryos. Should I do another IVF cycle? Is the question prior to an embryo transfer. Also individualized. I'm sorry, you may hear me say that quite a bit, but it truly is. So at 33, this is a more favorable reproductive age than it might be 10 years from now. But part of this depends on the number of kiddos you ideally want in your family. So if the goal is going to be a large family and that's what feels the best for you, then yes, going through another IVF cycle when you're at a younger age is favorable. For example, if you become pregnant, yay, with one of the embryos, that's fantastic. There is a time period in which you're not able to go through IVF. You're carrying a pregnancy, perhaps, or there could be complications from a pregnancy that take time to recover from. And then there's recovery with the newborn. And if breastfeeding or nursing is part of the process, all of that occurs such that it could be a couple of years, maybe a year and a half, maybe a year before you come back in for an IVF cycle. And at that point, age has progressed. So this may be less of a concern when we start family building at younger ages, more of a concern when we're family building at older ages. Now, there is also a financial component to this that I think is certainly individualized to you. If there's insurance coverage, sometimes insurance coverage has some guidelines that are pertinent. If one is not using insurance coverage, then this choice can be made based on the number that you're hoping to have in the family through this process. Is a morula or blastocyst a better candidate for biopsy for PGT testing? So PGT testing, this is pre-implantation genetic testing. This is a process that occurs after embryos have developed. They're in the culture environment for 5, 6, and 7 days. Once they've reached a stage in which cells can safely be removed from the embryo, that's when the biopsy occurs. And in most cases, a morula is more compact. It's looks a little bit more like a golf ball than what a blastocyst may look like. A blastocyst has a little bit more space in it, and in general, it is a safer point in which to remove cells for the biopsy. Now, this will depend on each embryology laboratory, but in general, the embryos do need to make it to the blastocyst stage for the biopsies that are commonly done in my area. Okay, so those are some of the questions we have, and now I'm going to start going through the Q&A. Okay, what is the chance of success for unexplained infertility after 5 early losses at age 30? I am sorry to hear this. 5 losses at the age of 30 is extraordinarily difficult, and I can imagine what you might be going through. There's some testing that would be recommended prior to an IVF cycle if that's what the thoughts are for becoming pregnant. Even in an unassisted pregnancy, there's some basic testing that most reproductive endocrinologists would recommend for you that could help change the outcome of your next pregnancy. So I certainly would recommend a consultation to go through some of what is involved in a recurrent pregnancy loss evaluation, and the probability of success is quite dependent on what is learned during that process. If everything comes back completely normal, then IVF is an option because there is a chance of testing embryos, and perhaps that will give you some information as to what might the embryos be looking like prior to transfer. But that's not the only option that you will have. I think that I hope that you are in good hands and find somebody that can help you more specifically with this. And I'm sorry you're going through it. I wish you the best. Going on to the next question. What are your favorite protocols for DR? So diminished ovarian reserve. And I chuckle a little bit because I love IVF and I love going through this. I know it's not fun when it's not a fun process, but I'm passionate about my work. Perhaps that's a better way of saying this. For diminished ovarian reserve, in general, I would typically start with either a protocol that uses FSH and a combination of FSH and LH or HCG with an antagonist, which is a medication that prevents ovulation so that we can override the body's normal mechanisms to ovulate early and get to an egg retrieval by recruiting as many follicles as possible. If the DOR is quite significant and there's been prior cycles, then perhaps a microdose Leuperon flare would be appropriate. This is the type of protocol that allows the pituitary gland to make FSH and LH kind of surge on its own. So your body's making endogenous hormones, and then you start giving yourself exogenous, so external hormones through shots of FSH, maybe a combination of FSH and menopur, depending. That works quite well if your pituitary gland can respond to that flare mechanism. Now, not everybody's pituitary gland is doing well enough to participate with the Lupron, but those are the two that I generally start with. It doesn't mean they're the only ones. There are so many. Sometimes there's minimal dose stimulation protocols that are most appropriate to start with as well. But I would say that those are two very common ones to be used around for diminished ovarian reserve. I wish you the best. I'm going to go on to the next question. I have PCOS, 3 failed IVF cycles, and starting a third. Are there supplements for egg quality? So this is an individual with polycystic ovarian syndrome, which infers that there's some difficulty with communication between the ovaries and the pituitary gland and the ovaries really ovulating. It's a metabolic syndrome as well. So individuals are at higher risk for diabetes, high blood pressure, cardiovascular disease, and need help ovulating with either medications or in vitro fertilization if they don't ovulate on their own, which is a very common part of polycystic ovarian syndrome. This does not infer that there's abnormal cysts within the ovaries. I commonly say that only because it can sound kind of scary. Inositol is actually a supplement that has been started to be promoted within the literature. And I have personally had patients that have had some nice success with inositol products. These are not FDA approved, so they are off-label. Metformin is also a medication that some individuals would use to decrease the progression to diabetes, which is how it's indicated to be used, meaning if you have impaired glucose intolerance. There are other things that are potentials for supplements for egg quality and options during IVF, but those would be the most common. Next question. What is the starter protocol? What's the most aggressive option to start? A tough one. This question does need to be, again, individualized to the parameters that we're able to see. But higher medication dosages, such as FSH and Menopur or HCG, in high amounts would be an aggressive option to start. And sometimes this is with an antagonist, sometimes this is with microdose Lupron. Those would likely fall at the top, which is the same for the diminished ovarian reserve that was answered a bit earlier. Okay, moving on to the next question. We have low ovarian reserve. I'm going to read the question first here. This question is asking about how to stay hopeful. And there's more medical details that have been provided for the individual that is going through this. And I'm sorry, I can appreciate that it would be challenging. There are opportunities to be successful at 38. Case studies are difficult to quote. What I would tell you is I would likely remain hopeful if there are embryos to transfer. If you're doing IVF, then there's an opportunity for pregnancy. There are other options as well. You know, some people do choose to use oral medications because their bodies respond quite well to those, or injections of medications with something like an intrauterine insemination. That's less commonly used, but remains an option in fertility care. Even minimally invasive or minimal stimulation protocols. To remain hopeful, I think we all do the best we can. Stress reduction, however you find stress reduction most beneficial to you. Acupuncture sometimes helps individuals with that. Exercise and movement is extraordinarily important. I think a good mindset, so mind-body connection is so greatly important when we're going through stressful times, and I think can really help in trying to remain hopeful during a stressful process. Sleep and really good nutrition. All of these things keep us healthier as individuals and work to help our outlook. So I would recommend looking at some apps as an initial start. There's some great mindful applications that you can find on, your app store. We also have a wellness program that could be very helpful at Boston IVF as well. And I'm sure there's some good local resources. The next question I have involves timing of IVF. I'm summarizing here, and travel. Yeah, it is hard. It's hard to add something into life, and most lives are fairly busy, whether it's with families or work or other things that take up our time and our energy. Um, Adding something like in vitro fertilization into that world can be very challenging. So I think it's great to think about how to minimize other external stressors during the process and how to maximize feeling good. So some of this is what we just talked about, the exercise, the sleeping, the stress. If traveling for you, if this is good travel, is less stressful, great. Maybe this is a good thing for you. Reducing work-related travel that makes you stressed might be a good idea. So it could go either way, I suppose. Difficult to tell you about travel plans, but generally, when you start IVF, you go through an initial consultation, which is what you've identified here. The consultation is scheduled with a physician, and then a list of tests would be provided to you based on your conversation. The testing is often timed to a menstrual cycle if it's testing for somebody that is ovulatory and has a uterus. That takes approximately a month to complete. I should say less than a month. It's generally an appointment on the third day of a menstrual cycle to look at hormone testing, to do an ultrasound. This is a vaginal ultrasound to count the number of small antral follicles, which are where the eggs are resting and waiting in the ovaries. And then later in a menstrual cycle, somewhere between the fifth and the 12th day, it's not uncommon to have a uterine cavity evaluation. This can either be done with placing water in the uterus and looking at the shape with an ultrasound, and then looking at fallopian tubes as well by agitating some saline and air and letting that saline and air go through fallopian tubes and watching that happen. Or with dye. Dye is placed in the uterus, and fluoroscopy is used to watch the tubes and make sure the tubes spill the dye out. If there is sperm involved, then a semen analysis is also recommended. Sometimes that can be a challenge to schedule just based on work schedules, but we have many appointments available for that. I would say that within a month, you've completed testing. If you've opted for genetic testing, that takes a few weeks to come back, and you're meeting with your physician to review results and talk about plans for IVF if that's what you're anticipating. And it sounds like you probably have a good idea that that may be your next step. If there's insurance involved, things go through a process of checks and balances to get submitted to the right individual so you have a prior authorization. Medications need to be ordered and then planned depending on where you're doing in vitro fertilization. It could be that you're in a center that has specified times that operating rooms are running, or you could be that you're in a center that is operating every day of the month. So some of that will play in. So travel is extraordinarily difficult to predict right now, but I would say limiting travel as much as possible would be beneficial if it's a vacation, I'm sorry. I really hate to say that, but until you know a little bit more, it's really hard to predict. Now, you can take time for a vacation and then come back and do an IVF cycle. What I would recommend is that you still look at the CDC website to think about Zika and other travel precautions, and make sure that you're safe while you are traveling. But you don't have to enter into an IVF cycle immediately after going through testing and meeting with your team. You can wait. In general, things would be updated, like blood work and the uterus and sperm, within a year, is pretty common. However, you do have time from the start to when you actually begin your IVF so that you can have some options. And I love vacations, so I hope if you do go, it's somewhere exciting or just relaxing. Okay. Let's see. Can you explain the PGM timing process for a known carrier condition? Is that testing done at the same time as PGT-A, and does it take longer? This is an excellent question. So PGT-M is looking at a specific gene. It takes longer to get into an IVF cycle because there's more preparation. There is a need to meet with a team of individuals that can help you determine if this gene can be screened for and what needs to go into developing the right tools to have the gene screened. Now, that can take weeks to months at either end, at the beginning or after. So I do generally recommend that there's just a little bit of patience at the beginning because it takes some time. And most of the time, this is done at the same time as PGTA, meaning you can select the PGTA as well, or you can try to separate the two. But it is performed through a biopsy on day 5, 6, or 7, just like it is for the genetic testing for aneuploidy. But yes, it does take a little bit longer time. Okay, let's see what we have next. Where in your cycle do you have to be to start? Actually, typically we're starting with a menstrual period, but there are other options. So some people can start during different stages in their menstrual cycle. Most commonly, it's with a period. Some people don't have the time, and do need to start sooner, and that can happen in different phases. Can you talk a little bit about progesterone, especially if you're testing your levels at home and they seem low? Well, progesterone is a hormone that is produced by the corpus luteum after ovulation. So during a normal menstrual cycle, you generally will recruit a follicle. That follicle grows with others, but it's going to become dominant. And once that dominance happens, the other follicles that wanted to join in get reabsorbed. It's kind of sad, but this is how ovarian reserve changes with time. You then ovulate the egg from the dominant follicle, and progesterone is predominantly produced at that point. Progesterone is highest about 7 to 8 days after ovulation, and then it will start to decrease, which is when a period happens. There's also some estrogen being produced at that time. Now, progesterone fluctuates quite a bit. It can fluctuate eightfold within 90 minutes. So it's really challenging to test progesterone levels and have them give meaningful answers aside from did I ovulate? So the way that I typically use progesterone is if somebody is uncertain if they ovulated, we check a progesterone level about a week later, and it should be greater than 3. Otherwise, it's really hard to interpret levels to say, do I have enough progesterone available? Most of the time during fertility treatments, progesterone is used in the luteal phase. I think this it's not uncommon, but testing at home may not be the most reliable. Okay. What are your thoughts on hysteroscopy for infertility, and would it be appropriate for one? So hysteroscopy is an option to look at the uterine cavity. There are options to do this in the hospital, but very commonly in an office setting. And they're appropriate prior to any fertility treatment. That way, we're looking at the uterine cavity, excluding the presence of any structural lesions, such as polyps or fibroids, things that could make it difficult for, or more difficult for pregnancy. Also looking at scar tissue, if there's been any prior uterine surgery. So very appropriate prior to any care. Also appropriate with any symptoms of abnormal bleeding, irregular periods, spotting. Appropriate after a miscarriage, for example, just to make sure that the uterus still looks okay. There are many indications for a hysteroscopy, and it's not uncommon that it's used as part of the fertility evaluation. It does not commonly get combined with being able to look at the tubes. So more typically, we're looking at something like placing water or dye in the uterus and the fallopian tubes, but any interval updates, a hysteroscopy would be very appropriate for. Um, I think I'm going on a lot about hysteroscopy. Hopefully yours goes well if you have one. I'll move on to the next question. Does Boston IVF monitor development past day 5? Say to day 6 or 7, or is there a hard stop at day 5? Thank you for asking this question. I believe this is referring to embryos. So typically embryos are in the culture environment for about 5 days before they develop into blastocysts, but some embryos just aren't developed at that stage. So we do watch them until day 6, and in cases in which we are doing genetic testing on embryos, we also will look at the embryos on day 7. Embryos would be biopsied if that's the plan when they are ready to be biopsied, but we try to give them every opportunity possible. If there's not a biopsy involved, generally we are freezing embryos that are extra on day 5 or 6. So it depends on your plan. But yes, there's not a hard stop on day 5. All right. So I know that time is of essence here. I have so many questions that I'd like to get to for you. I'm going to try to go through a couple of these really fast, and then I'm going to thank you for your time. Causes for a hydrosalpinx, good question. So there are causes that involve infections, like prior infection with gonorrhea, chlamydia, pelvic infection, prior surgeries that have caused scar tissue, that have been, are tugging on the tube the wrong way, that you um, didn't know about. Endometriosis, which is something that can cause scar tissue in the pelvis and change the anatomy of the fallopian tubes, can cause a hydrosalpinx as well. Sometimes we don't have a clear answer. Again, very quick answers to that question. I'm sorry to try to move on. How long does the process take for one cycle? If this is one cycle of IVF, it's generally, if there's pre-medication that's been asked to be used by your physician, it could be a couple weeks of a pre-medication stage. But then once you start injections, you're about 10 to 12 days of injections with, some leeway there, of course, with an egg retrieval that happens 36 hours later. And then if an embryo transfer is planned, that might happen 3 days later, it might happen 5 days later. So once you're actually in a cycle, it's quick. Now, if you're referring to an IUI cycle, generally start with the period. You're ready to ovulate somewhere around the middle of a cycle, which could be day 12 to day 18. There's a lot of variability here. And then an IUI would happen a couple days later, and then we're waiting for the pregnancy test from there. So I think I'm talking too rapidly now, and it's probably a good time for me to say thank you and that I'm grateful to all of you. I hope that your journeys all bring you to the family that you are hoping to have, and a very healthy one at that. So, thank you so much for your time. I'm grateful and have a great day.